This conference will now be recorded.
Welcome everyone to the first session on the CPQR course on incident reporting. My name is Jean-Pierre Bissonnette, and in this session we will go over the incident learning techniques and methods available through the literature and that have been used in the healthcare system. So I'm Jean-Pierre Bissonnette. I'm a medical physicist at Princess Margaret Cancer Center in Toronto. What you'll learn in this session is the basic causes of incidents and how a properly applied incident learning framework can help reduce incident propagation and learn from setbacks. Measuring what goes wrong in healthcare involves counting how many patients are harmed or killed each year and from which types of adverse events. And that's the very basic thing. We want to make sure that we do a good job without making mistakes. And once we identify those mistakes and analyze them, we can identify priority areas, understand them, what are the causes, and remove those causes eventually so that we can make our systems safer, more reliable, more efficient. These are all good, beneficial side effects from removing potential hazards. So in this part, we will explain methods for incident learning with their respective pros and cons. Incident learning fits in the global quality improvement cycle that we all understand in healthcare. Essentially, we are trying to measure harm, understand the causes, identify solutions, evaluate the impact of the solutions, and translate evidence into safer care before starting the cycle again. So incident learning is squarely in the area of understanding causes. There's four very basic methods of collecting data seen in the literature. First is observation, and this is more for the immediate incident happening when someone observes something going wrong and tries to manage the situation on the fly. The other concerns self-reports, especially using interviews and questionnaires in order to learn what's going on in the clinic, but perhaps at a broader scale and at a higher level. We can also be testing, try to change things, our workflows and our processes and see what comes out of that. Physical evidence or document review. This could be from policies and procedures that are produced locally to government reports or actual scientific literature or journal articles. These four tools were originally designed for high-risk industries in the 70s and 90s and have started to be applied to the healthcare system, or at least in the radiation oncology system, back in the year 2004-2005. There are several measurement methods available that can be either prospective, that means looking forward, or retrospective, which means looking back at how we've done this and how we've recorded things. The prospective methods usually list direct observation of patient care. So some auditor, either internal or external, comes in, looks at the way you do things, and may issue some advice or recommendations. Or alternatively, one can observe an actual incident and try to fix it, manage it on the spot, and write a little report to be submitted and disseminated later on. We can also look at cohort studies, which would mean looking at a cohort of patients and compare how we did in terms of safety and quality with previous cohorts and demonstrate improvement in care. And of course, clinical surveillance, again, being aware of what is going on, being vigilant, and all that good things that can help us detect errors on the fly and fix them. Retrospective methods include record review, be it charts or electronic medical records, images, you name it. Administrative claims analysis or malpractice claims analysis. And in these two buckets, I include also government reports. So some national or provincial authorities can come up with reports that are specific to incidents that have had impact. And these documents are made public and available and can be analyzed and read so that people can learn from someone else's incidents and build resilience into our own. Morbidity and mortality conferences or autopsies, often these are very frequent in other domains of healthcare, but in radiation oncology, several clinics are conducting similar conferences where staff is presented with the data and the history of specific incidents that may have led to injury or mortality, and in a systematic way, and staff are given an opportunity to discuss, learn from, and integrate that knowledge into their clinical practice. And of course, incident reporting systems, which will be the main focus of this course. The problem with incident reporting is that there's not one method that is good for everything. And here's a graphic that I've reproduced from this publication, Thomas and Peterson, back in 2003. Essentially, the graph presents the spectrum of incidents, be it from latent errors that can be revealed better with the methodologies below, to active errors that can be resolved by, again, direct observation and actual adverse events. So some tools like incident reportings, autopsies, malpractice claims, and analysis are much better at detecting latent errors and give you the leverage to change your ways and workflows in order to remove these latent errors. Remember that a latent error doesn't mean that it actually hits the patient. It's usually detected as a near miss, but multiple reports on latent errors empowers users to do something about it before it actually manifests itself and the patient severity is increased. And as I mentioned before, active errors are best detected and measured and analyzed by direct observation. And adverse events include clinical surveillance in the sense that these need to be managed medically because the patient has been harmed to some extent. So these methods can provide important and actionable information about our systems, but they also have weakness. So no one is perfect. And again, we want to use our methodologies to find out facts, involve the expertise of specific individuals to drive our analysis, which will lead to conclusions and recommendations. But we want to make sure that the recommendations and conclusions are free of bias and that the recommendations are actionable and reasonable. Clinical methods that are used that we may be familiar with involve morbidity and mortality conference, root cause analysis, and these methods are usually good for single cases at detecting latent errors. Again, a single incident report is issued and quality staff will spend time analyzing, dissecting it, and issue recommendations based on it, based on the single incident. The information can come from multiple providers. So an incident usually involves multiple people at different stages, at different times, and at different locations. In a literature review of incident reports that was done back in 2005, Wolcinowicz and colleagues identified 138 studies about incident reporting using clinical methods, and 114 papers that were descriptive and issued commentaries. And it turns out from this review that comparison with standards and classification of incidents were the most frequent papers out there. However, there were also non-negligible tools that were reported in the literature, including critical incident technique, significant event auditing, root cause analysis, and human factors and organizational methods. And each of them offer a point of view or a perspective on what is it that happened and can lead to different recommendations. So let's focus for a moment on root cause analysis. Root cause analysis uses tools such as the fishbone diagram or Ishikawa diagram shown here on the right that helps us identify the steps of a process and the workflows and the causes classed either by equipment, process, people, management, environment, and materials that may lead to a problem being caused. So root cause analysis focuses on system improvement. It implies that you know your process flows and your systems quite well, so you can identify which step was or needs improvement. It uses a variety of techniques to produce these Ishikawa diagrams and is understood to be a complete methodology. However, investigators need training. If we were to ask two different people, equally expert, to define an Ishikawa diagram, they probably would come up with slightly different answers. And we need to make sure that we speak the same language and that we understand each other between investigators. It's also quite time consuming. Building these workflows requires a lot of time, but has a lot of benefit. But the issue of how do we have the resources to invest to build these workflows is a pending question pretty much everywhere. It can be overly complicated and does not guarantee a complete answer. And it's also expensive, especially in terms of staff time, to come up with a full realization and analysis. The root cause analysis asks those questions. What happened and why it happened? And as a beneficial side effect from this analysis, it points out to ways to prevent it from happening again, and perhaps ask you or make you think about how will you know that you're safer. And on the right, I show an example of the 5 whys technique. Essentially, it's very simple. When interrogating or having a discussion with a worker who has witnessed an incident, you ask why until you reach an actionable level. So here's the example. This morning, I was caught speeding. Why was that? Well, I was late for work. Why was that? I got a plate. So notice that these whys and reasons that are being listed up there are not really actionable. We don't have a concrete way to remove the causes. Now we go to the next why. Why did I get a plate? My alarm clock didn't work. Why didn't it work? Because the batteries were dead. Why? Because I forgot to replace them. So this is getting close to a cause that is actionable. So the action from this series of whys might be this countermeasure, either to get a plug-in alarm clock or replace batteries at a set time before they run out. The next methodology that I want to go over is a provider survey. Surveys of staff might be good for identifying latent errors. It also looks at data that is otherwise unavailable, either in a focus group discussion that is recorded and interviews with individual staff. It benefits from the wisdom of crowds, and it can be comprehensive. However, those surveys may suffer from hindsight bias. And hindsight bias sees the event as having been predictable, despite there having been little or no objective basis for predicting it. Insight bias. So essentially, insight bias is I told you so. Oh, it's always been like this. And it's a natural reaction from the human mind to attempt to rationalize something for which we have no ideas. It might be based on experience, but not necessarily directly from observation. Insight bias may cause memory distortion, where the recollection and reconstruction of the content can lead to false theoretical outcomes. It may also lead to overconfidence and malpractice. So this is something to be aware of when discussing with people, that these biases are recognized and diffused so that we can come up with real good recommendations and analysis. Again, surveys may also suffer from low response rates. So meetings get canceled and the response rate from a written or electronic survey, given the fact that we're being bombarded with them continually, might be low because of fatigue. Surveys may also be infrequent in the sense that the occasions to learn from these surveys may not be very frequent, and it can be laborious. So again, the resources use rising its head. There's types of survey questions to help you design them. It could be closed-ended questions with standardized items and scales from 1 to 5, going from no to average to yes, or simple yes, no. Questions could be open-ended. Typically, the person who answers the survey has to enter text in a text box, or it can be semi-structured, as in the case for interviews. The design of a survey needs to be requires careful thought. A cross-sectional survey could be made confidential, anonymous, using free text and fixed response questions. The procedures need to be understood, so the survey can be mailed out and mailed back, and with reminders, and it's the same with email reminders. So again, realize that when a survey is being sent, you're competing with several surveys being sent more or less at the same time, and that people might not want to be answering surveys throughout the day. And the design of the survey should be chosen to provide in-depth responses and ability to test hypotheses. Don't just copy paste a survey that someone else did because they were seeking different answers than you are. Be very clear on the questions or the answers that you're looking for, and design the questions to be aligned with your objectives. Other self-reported methods that could have been used could be semi-structured interviews, small focus group discussions, or one-on-one interviews. Malpractice claims analysis, or if you like, literature, legal, governmental, or scientific. These are good for latent errors, to learn what latent errors could be that happen elsewhere in your clinic. And it provides multiple perspectives, perspective from the patient, from providers, lawyers, government officials, regulators, and so on and so forth. And these reports are usually quite thorough. However, they may also suffer from insight bias and reporting bias. It's a non-standard source of data, and it's infrequent publication of those reports. So when a key paper comes out, it might be wise to have a look at it and see what could be learned from that particular report. However, every clinic doesn't exactly work the same. The workflows are different, the process maps can be different, the equipment is different. So often seeing a report being issued, the conclusion may very well be that this doesn't apply to my situation. I just want to go over as examples findings from recent cases that were culled from the media. Incidents can be found or analyzed through independent learning, through independent means. And obsolete documents can be identified, training issues can be identified, and supervision, and so on and so forth. And this is an example. This is the Beeston incident in Scotland, where a young patient, a young teenager who was receiving craniospinal irradiation, received a fatal dose. It turned out that after many years after the incident, that the actual radiation incidence was not the direct cause of her death. But at the time, we did not know that, and several investigations were made about that particular unfortunate case. But it did identify issues such that the lack of a clear commissioning or assessment of a change in workflow. They were essentially going from a manual-based treatment planning technique to a computerized a treatment planning technique that was poorly documented. And as a result, an untrained planner was trying to perform the work, but couldn't do it because the guidance documentation was lacking, and the supervision of that untrained planner was not as tight as it could be. As a result, staffing issues were identified. We didn't have staff. They did not have enough staff to supervise the radiation to this patient. Another example that was highly publicized in France was a systematic overdose of prostate radiation therapy that led to 7 fatalities. A calibration error was linked to the introduction of new machines. The technology was poorly introduced and understood. Software was running in English, whereas the staff were speaking French, and a lot of other mistakes were made in the commissioning of the equipment. Staff shortages were also outlined in bureaucratic complexity, and also even more damning was the doctor's desire to hide the truth from the victims and their own attempts to play down, even disguise their mistakes. And as a result, the physicians and physicists were jailed for radiation overdose. However, despite all of this, this led to interesting data that we now know about the implications of overdoses in the fractionation schemes that were used. And as a result of these series of very unfortunate incidents, we now know a little bit better how toxicity to the prostate, to the rectum, and other pelvic structures can affect prostate patients. And closer to home in Canada, again, we had a report about staff shortage leading to a radiation error that affected an ortho voltage unit at the Ottawa hospital. So again, fortunately in this case, the magnitude of the error was small, but it occurred frequently, essentially highlighting the lack of physics staff at that particular clinic at that particular time. So the main points from these reports is that there are multiple breakdowns involving individuals and system factors. It's rarely just one cause that will lead to a lawsuit, a claim, or a government report. Awareness of the most common types of breakdown and factors could help to identify and prioritize strategies to prevent errors and their dissemination to the community. Staff and training issues are often brought forward in these analyses. And again, these reports usually involve patients that had some severe impact on their outcomes, their lives, or their toxicity. And this is a great way to engage management. What we can do can be harmful to patients. The next tool that I want to talk about is reporting and learning system. Incident learning systems are good at detecting latent errors in your own clinical setting. Given time, it can provide multiple perspectives from various disciplines and various individuals. It can be instituted as a standard procedure, and the introduction of a common tool like NSER-RT that can be used pretty much everywhere in Canada, irrespective of your clinical setting, can facilitate making this a standard procedure. The learning system usually has a list of causes, reasons, process maps that can help us identify common factors and trends from aggregated reports. It, however, also suffers from reporting and hindsight bias, and the learning have a limited portability to other clinics. So again, what I learned or the incident that occurred in my clinic might be inapplicable elsewhere. However, a lot of work has been occurring both in Canada and the United States and in Europe about learning systems. And a few years ago, Eric Ford led a work group that came up with a consensus recommendations for how these learning systems ought to be structured such that the data can be acquired systematically, but also classified systematically in ways that are meaningful to us. And here's an example of one of the several tables found in this guidance document listing important features of radiation reporting systems in radiation oncology. And for each features, a list of requirements and notes have been set. And this is a very thorough document, but it's at the basis of the NSER-RT tool that CPQR has helped design and endorses. So essentially, the NSER-RT is a centralized Canadian database where each incident can be reported using a very structured way, such as the treatment technique, total dose prescribed, and so on and so forth, so that the incident can be analyzed in very thorough detail. And given that the database is in a Canadian federal agency, that means that we abide by Canadian laws and we have high security for patient-related data. So here's the initial event form from NSER-RT, asking for location, sublocation, which room this happened, an additional location, how the incident or the event is classified, open text for the narratives, treatment technique, identifiers, date and time of the event, and so on and so forth. And you will see many examples of its application in this course. One interesting component of a taxonomy or an error classification system is branch questions and classifications. So essentially, one can dig a feature or parameter of an incident in multiple levels. And if a branching level occurs that is not applicable, you can just not stop going that route and focus on the choices given to you at a much deeper level. One problem, though, with taxonomies is the validity, the face validity of test results. And this is a key table from a publication by Lam et al., published in 2014. Essentially, experts in incident reporting were given same incident reports, and they had to classify them according to the INSER-RT categories and nomenclature. And the first time around, the agreement between the testers sometimes was quite high, but also at sometimes quite low. And the hypothesis is that the experts perhaps had a different understanding of what these classifications of the taxonomies actually meant. So they met together and went through the taxonomy elements, and until it was clear in their head what each element meant. After this session, another cohort of incident reports were submitted to the same individuals. And this time, the level of agreement between the users raised significantly, reaching the 80s to 90% level most of the time. Still not perfect. There's still some discordance. So even though the users, the test subjects, were submitted to the same education, there was still some variation in how the incidents were reported. And we have to be aware of that because the conclusions, the recommendations will change according to how the incident was classified. So in summary, there are different methods to measure and understand errors and setbacks, and they have different strengths and weaknesses. We talked about provider interviews and surveys. We talked about malpractice claims analysis, government reports, or scientific literature. We talked about reporting and learning systems, which will be the focus of this course, direct observation, and cohort studies. And mixed methods approaches, so using one or two or three, if you have the time, approaches can improve understanding and help go deeper in the understanding of your systems, your latent errors, and how to mitigate them. Thank you very much for your attention, and I hope you have a great course. Thank you.
This conference will now be recorded. This conference will now be recorded.